thankfully, patients with follicular lymphoma are living for very long lives these days, absent the patients of those early progressors. But unfortunately, that means they're going to need third-line therapies. Pierluigi, what are your treatment options then, and what are you doing?
Sure. So in terms of official indication, PI3K inhibitors. For example, in the United States, there are indications for 3 different PI3K inhibitors. Idelalisib was the first one. The second was copanlisib, and then the last one, the last year, was duvelisib. On the contrary, in Europe right now, there are only idelalisib. So potentially, I come back to the second line. Potentially, when the advent in Europe of R square could be squared the second line for the most part of this patient. At the same time, the third line right now, independently by North America or Europe, is PI3K inhibitors. So the real problem of PI3K inhibitors it could be the toxicity. In particular, for the first one, Idela, there were several patients with diarrhea, colitis, pneumonitis, grade 3 and 4, in particular after 6-7 months of treatment. And it's a different situation when you compare with copanlisib, because there is a difference in terms of subunity A, and the toxicity, the safety profile is quite different, less infection, less colitis and pneumonitis, but there is hyperglycemia, hypertension, but it's quite easy to control, to manage this kind of side effects. At the end of the day, you can have an overall response rate of more than 50-55%. The median duration of the response is 11-12 months. So it's quite interesting, innovative biological treatment, oral formulation for the first one, Idela. It's more difficult because it's intravenous administration for copanlisib. But anyway, this is the represent in both continents right now the third-line treatment for follicular lymphoma.
You brought up some of the differences in the adverse event profile. Of course, the mechanism of action of the 3 different PI3 kinase inhibitors is a little bit different. Maybe not the mechanism of action, but their specificity for the isoform subtype. So of course, Idela was a pure delta inhibitor of the isoform. The copanlisib is more of a pan inhibitor, but definitely hits alpha as well. And then duvelisib is both a delta and a gamma inhibitor. And we're not sure, right, that at least in today that there's a differences in that hitting those different mechanisms, those different isoforms make a difference clinically, at least in multiple relapse follicular lymphoma. But there are theoretical differences of why that might be.